is being shared.
Sir?
Monica's screen is shared.
Yes, sir. First, I'll give an introduction about this.
Okay.
2 minutes. Yeah.
We are live now.
Good evening, everyone. I am Dr. Maunika, medical advisor from Shield Healthcare. I welcome you all for today's session. And before starting the session, I would like to give a brief introduction about Shield Connect. Shield Connect is knowledge sharing platform, basically gynecology, infertility, and pediatric, and it has various blogs, webinars, and it is connected through all over the doctors who are connected to Shield Healthcare, and we have we even have special occasions, and we even do some newsletters, we do awareness programs, and there are a lot more. You can just open the Google and you can follow the Shield Connect page in all the social medias, so you can get more and more information about gynecology, infertility, and pediatrics. And I welcome
Hello. We can't hear you. Should I start the presentation?
Just a second.
And I welcome Dr. Banu Teja for today's session. And the topic is benign prostatic hyperplasia. Is an MBBS urology and a consultant urologist and microsurgical andrologist. He's a specialist in lasers and laparoscopy, and he's working in Citizen Specialty Hospital, and he has his own clinic, Teja Kidney Center, Banjara Hills. I welcome you for today's session, sir, and I hand over the session to you.
Thank you, Shield Connect, for giving me this opportunity. So I will start my presentation. Yeah. So can you see my slides?
Yes, sir.
Okay. So today I'll be talking about benign prostatic hyperplasia. This is a common condition which I usually see in my outpatient clinics. Not only urologists, many physicians and general surgeons do come across this condition. So we'll be discussing about this in detail today. So what are the learning objectives? The main learning objectives are to understand the prevalence pathophysiology of BPH in men, to evaluate the risk factors, to diagnose, to know the diagnosis, and then the associated male urinary tract symptoms associated with BPH, and also to be familiar with the current approaches of management. And what are the red flags where the general physicians or surgeons, when they come across these BPH patients, when do they have to refer to a urologist? This is what we are going to discuss today. So coming to the first section, pathophysiology, benign prostatic hyperplasia is a histologic diagnosis that refers to the proliferation of smooth muscle and epithelial cells within the prostatic transition zone. So there are mainly two clinical concepts. One is the BPH mainly affects the periurethral and transitional zones, and it starts away with small nodules which join together to form an adenoma. So coming to the prevalence, BPH markedly rises with increasing age. So it's very rare in the young age group. As the age increases to 81 to 90 years, almost 90% of them do have prostatic enlargement. So there are higher prevalence of BPH symptoms among Asian men. So what is the impact of BPH on quality of life? So there is a Probe 2 survey which has been conducted in various countries across Asia, Pacific, Latin America, and some Commonwealth states, where they have found 20% of the patients do have severe symptoms, and 1/4 of these patients have a major impact on their quality of life. So the most common concerns seen in all of these are discomfort or disturbed sleep, fear that all these symptoms could be because of some cancer. So what are the BPH manifestations, and what are the components involved in its enlargement? So there are mainly two components. That is a static component, where there is a enlarged tissue which elevates the bladder neck and causes obstruction to the urine outflow. Other one is a dynamic component. Because of the enlarged gland, there is a lot of resistance on the urethra and on the smooth muscle tone. So this also in turn causes severe lower urinary tract symptoms. So what are these lower urinary tract symptoms? It is a broad condition which is divided into three symptom complex. So one is storage symptoms, voiding symptoms, and post-micturition symptoms. Storage symptoms include frequency, nocturia, urgency, urge incontinence. Voiding symptoms are slow urinary stream, interrupted stream, hesitancy, straining to void, and terminal dribble. Whereas post-micturition symptoms include feeling of incomplete emptying and post-micturition dribble. So LUTS, when suggestive of bladder outlet obstruction, is a term used for cases with predominant complaints of voiding symptoms in the absence of infection. So this is very important to know. Coming to the relationship with BPH, BPE, bladder outlet obstruction, as well as lower urinary tract symptoms, this is a complex association with the overlap of a lot of symptoms. So we do evaluate these patients thoroughly and a stepwise manner to treat them accordingly. So coming to the complications of BPH, so the most common complications seen are acute urinary retention, where there is sudden blockage of urine outflow, bladder stones, decompensated bladder, recurrent UTIs, renal insufficiency, and hematuria. So coming to each one of them, acute urinary retention, there is precipitated urinary retention and spontaneous urinary retention. Precipitated urinary retention we usually see when there are some triggering factors like some non-prostate related surgery or because of some medications or due to anesthesia. Patients tend to go quite commonly into retention after any surgical procedure. So this is known as precipitated retention. And spontaneous retention is all other retention episodes which occur suddenly. So coming to recurrent UTIs, UTIs are most commonly seen in BPH patients. The most common reason is because of significant urinary stasis, because of the outflow obstruction. So we call them recurrent when there are more than 2 or more episodes within 6 months. So that is when we treat them as recurrent UTIs. Bladder stones also are commonly seen with BPH, and we tend to treat both bladder stones and BPH together most of the time. Renal insufficiency is seen when there is chronic long-standing outflow obstruction leading to a lot of pressure on the kidneys. That is when the kidneys starts failing and tend to go to failure. Decompensated bladder, when there is a chronic outlet obstruction, the detrusor hypertrophy occurs. So this hypertrophy leads to decreased contractility of the detrusor, and which in turn leads to a lot of urinary stasis. And hematuria mainly occurs due to the upregulation of vascular endothelial growth factor and increase in the microvessel density over the prostatic urethra, leading to hematuria when the patient strains or even when he passes urine routinely. So coming to the etiology and risk factors associated with BPH, the main etiologic factors are sex steroid hormone and growth factor related. So when there is a higher dihydrotestosterone, there is an increased risk of BPH. When there is higher dihydroepiandrosteronium, there is an increased risk of BPH. When coming to growth factors, there is a model which is proposed where the androgen regulates the transforming growth factor, which influences the fibroblast growth factors. These in turn regulate the prostatic growth. So these two factors play an important role in the etiology of BPH. So coming to other risk factors which influence BPH, so medical conditions like hypertension, diabetes, atherosclerosis, dyslipidemia, obesity are all increase the risk of BPH. Genetic factors do increase the risk of BPH. Age is directly proportional to the increased risk of BPH. Dietary factors do increase the risk of BPH. Physical activity and alcohol intake decrease the risk of BPH. So let's go in detail of each one. So as you can see this graph, it clearly shows that as the age increases, the BPH increases. So usually the volume also increases with age, but the volume has no relation with the symptoms. and the treatment protocol. So genetic factors, all first degree male relatives, there is a 4.4% relative risk of BPH. Fathers of the same proband have 3.5% relative risk, and brothers of the same proband have 6.1 risk of relative risk. And it is most commonly seen in monozygotic twins as well. So coming to the medical conditions, atherosclerosis and dyslipidemia, high triglycerides and low HDL levels are associated with increased BPH incidence. Diabetes, elevated fasting glucose, hyperinsulinemia increase the BPH risk. Hypertension is associated with larger prostate gland volume and faster BPH growth rate. Obesity, higher waist to hip ratio is associated with increased BPH incidence. And erectile dysfunction also has a positive relation with the BPH and their associated lower urinary tract symptoms. So coming to dietary factors, a modest direct association between the BPH and intake of total energy, protein, and specific long chain polyunsaturated fatty acids is seen. So coming to physical activity and moderate alcohol consumption, they do tend to reduce the risk of BPH as well as lower urinary tract symptoms. So coming to the diagnosis and investigations. So the most important part in evaluating a BPH patient is the medical history and physical examination. Where in medical history, we tend to see the duration and severity of the symptoms, whether there is any history of incontinence and hematuria, how is the general condition of the patient, and whether there are any associated neurological conditions, whether the patient is having any constipation, which do cause a lot of UTIs in these patients, whether the patient is on any medications, and whether there are any prior urinary tract interventions, or whether there is any family history of prostatic disease. And coming to physical examination, apart from the general physical examination, per-abdomen examination to see whether there is any palpable bladder is a very important thing, as well as a digital rectal examination. Digital rectal examination is important to see the prostate size, how is the prostatic mucosa, how is the prostate consistency, whether it is tender or non-tender, whether there are any associated nodules. So all these points play a very important role in the management of prostatic enlargement. So coming to the investigations, the urine analysis gives us an idea of any urinary infections, whether the patient is losing any glucose in the urine. So serum creatinine is done when there is where we can see whether there is any renal insufficiency in these patients. And voiding diary is usually reserved for those who have mostly storage symptoms like frequency and urgency, or when there is a lot of nocturia predominantly. That is when we do a voiding diary, but usually it is not advised for all the patients. The other important objective investigation which we do in our outpatient clinic is International Prostate Symptom Score, where we score each of the symptoms and their severity, and also include the quality of life score. Based on this, we divide the symptoms into mild, moderate, and severe symptoms. So this we tend to do before starting the treatment, so we can assess the symptom score improvement after the treatment, after the patient is on the treatment. And another two important investigations are PSA and transabdominal ultrasound. PSA helps to detect whether there is any prostate cancer or an associated prostatitis in the patients with these lower urinary tract symptoms. So PSA value of more than 4 definitely needs further evaluation. So transabdominal ultrasound is commonly done for all the patients who have lower urinary tract symptoms. Here we see the prostate size, volume, the amount of post-void residue which is there, whether there are any bladder stones in the ultrasound, or whether there is any hydronephrosis. So the red flagging signs which should be seen in an ultrasound are bladder stones as well as a hydronephrosis. So coming to what are the special tests, so which we urologists do commonly perform is a uroflowmetry, where we see the stream pattern of the patient, how he passes, how is his urine stream, how much time is he taking to void, how is this maximum flow of urine per second. This is all we see in the uroflowmetry to assess this urinary flow. And we also do urodynamics and a transrectal prostate biopsy in a special settings when we see any specific signs on a digital rectal examination or something which is not correlating to his small prostate size and having severity of symptoms. That is when we need to see whether the role of urodynamics is there or not. So what are all the conditions for urological referral? This is mainly for general physicians to have a note of it. Definitely when there are any complicated conditions associated like hematuria, urinary retention, bladder stones, or UTIs, definitely patient has to be immediately sent to a urologist. And when there are other associations like incontinence or a hard prostate on a DRE, when there is a palpable bladder, maybe he's in acute urinary retention, he might need catheterization. So call in your urologist immediately. When there is a PSA of more than 4, definitely he needs to be further evaluated to rule out prostate cancer. And when there are 2 bothersome symptoms and which are not improving with the routine medical therapy, these patients do have to be sent to a urologist for further evaluation. So coming to the management of BPH and male urinary tract symptoms. So usually the management is depending on the stage-wise approach. So these stages are usually not related to the prostate size. Prostate size has no bearing on the treatment of BPH. So usually stage 1 is considered when there is absent significant obstruction is absent, as well as there are no bothersome symptoms. Stage 2 is when there is no significant obstruction, whereas bothersome symptoms are present. And stage 3, when significant obstruction is present, as well as there are irrespective bothersome symptoms. And stage 4 is complications of BPH. So stage 1, we usually watch them, counsel them, and tell them for conservative management. Stage 2, we can start off them on medical therapy and then further see, follow up how they respond to the medical therapy. Stage 3, you can consider surgical options. And stage 4 is a absolute indication for surgery without any delay. So coming to the low stage, that is stage 1 patients, the conservative treatment includes education and reassurance and lifestyle modification, like modification in fluid intake, exercise, regular exercise, restriction of caffeine and alcohol intake, especially during the night times, relaxed voiding and double voiding techniques, bladder retraining, and optimizing the drug dosing schedule if they are on any anticholinergics or antihistaminics which might precipitate urinary retention. So periodic monitoring of these patients with regular examinations every 9 to 12 months. These are all very important in early BPH patients. So coming to the medical management of BPH patients. So what are all the drugs which we need to know? So the most important are alpha-1 adrenoreceptor antagonists, which are tamsulosin, alfuzosin, silodosin. The older group of medications are terazosin and doxazosin, which were associated with more side effects and are less used nowadays. 5-alpha reductase inhibitors like dutasteride and finasteride, as well as combination of these two. And anti-muscarinic agents are mainly limited to those who are having significantly storage symptoms like frequency, urgency, or urge incontinence. Phosphodiesterase 5 inhibitors like tadalafil, these also do play a very important role in the management of lower urinary tract symptoms. And others like some plant extracts and botulinum toxins are very specifically used. So coming to each one, alpha-1 adrenoreceptor antagonists. So the main mechanism is, as we all know, there are a lot of alpha-1 receptors on the smooth muscles, on the trigone, on the prostatic urethra. So these drugs block these alpha-1 receptors and result in a decreased smooth muscle tone. So this allows for relaxation of the prostatic urethra and better urine flow for the patients. So silodosin is the latest alpha-1 antagonist which we see, which significantly improves the symptom score and flow rate compared to alfuzosin and tamsulosin. So the main side effects which we have to know are abnormal ejaculation, which do occurs with these agents, something called floppy iris syndrome in those patients who are on these medications and who go for cataract. Our ophthalmologists do commonly come across this. And orthostatic hypotension is also was commonly seen with the older generation of alpha blockers like doxazosin and terazosin. Now it has significantly reduced with tamsulosin and alfuzosin as well as silodosin. So dizziness is also seen commonly. Asthenia is mostly attributed to the decrease in the blood pressure. So alfuzosin and tamsulosin have better tolerability than the older drugs. So the main clinical points to be noted in alpha blockers, they should be offered to those men with moderate to severe LUTS and those men who are planned to have a cataract surgery. They should finish their cataract surgery first and then followed by initiation of these alpha blockers. So 5-alpha reductase inhibitors, they mainly block the conversion of testosterone to dihydrotestosterone, leading to a decrease in the prostate volume. So usually the effect of these medications takes at least 6 months to decrease the prostate volume, and when they decrease, they do tend to decrease only 20%. So, but these inhibitors are also have given a good results in reducing the risk of urinary retention, and also those patients needing surgery also is reduced when the patients are on 5-alpha reductase inhibitors. So the main clinical points which has to be considered are they're mainly indicated for patients with larger prostate volumes and significant obstruction, and they tend to reduce the episodes of urinary retentions. So the combination of alpha-1 adrenoceptor antagonists and 5-alpha reductase inhibitors has been proved they significantly improve the symptoms and also the urine flow. So these are the studies which all have proved their efficacy compared to single agents. So the main clinical points are they should be offered to men with moderate to severe LUTS with enlarged prostates and with reduced max flow. These are the main signs where we have to give a combination therapy. So coming to anti-muscarinic agents, they mainly block the acetylcholine receptors in the bladder, resulting in the decreased contractility of detrusor muscle, as well as the decrease the abnormal contractions of the detrusor muscle. So these are mainly used for those who have predominantly storage symptoms like frequency, urgency, or urge incontinence. So the side effects should be kept in mind like dry mouth, dry eyes, and constipation. So patients with OAB are mainly indicated to use anti-muscarinic agents, and they can be used in combination with alpha blockers when there is a reduced uroflow or when there is significant prostatic protrusion. Then these are when both the combination of an anticholinergic as well as a alpha blocker does work better. So coming to 5-alpha reductase inhibitors, so these relax the smooth muscle in the bladder, neck, prostate, and urethra. So as well as it increases the blood perfusion in these tissues. So tadalafil may be considered in men with erectile dysfunction along with some associated lower urinary tract symptoms. So other agents like plant extracts have not been proven significantly. Botulinum toxin, yes, it does have an important role in cases of a retractable overactive bladder. So coming to the key messages of this talk. So the prevalence of BPH rises markedly with increasing age. BPH is most commonly manifested with lower urinary tract symptoms, either by storage, voiding, or post-micturition symptoms. So the highly recommended tests include history, physical examination, digital rectal examination, urine analysis, a transabdominal ultrasound, serum creatinine, symptom scores, as well as a voiding diary. So what are the main red flags which everyone needs to know about a BPH? Are urinary retention, bladder stones, UTIs, hematuria, urinary incontinence, palpable bladder, hard prostate, high PSA levels, persistent bothersome symptoms or poor response to medical therapy, do immediately act on these patients, send them to a urologist as and when you come across any of these important signs or symptoms. So the management is a stage-wise approach, as we have already discussed, and the pharmacological agents, as I have already told, alpha-1 blockers play a major role, along with combination of 5-alpha reductase inhibitors, anti-muscarinic agents, predominantly in those who have storage symptoms, phosphodiesterase 5 inhibitors, yes, they have an important role, and other agents like plant extracts and botulinum toxin with a very specific and limited role. Thank you. Thank you very much for giving me this opportunity.
Thank you, sir. Thank you for your valuable time and you have taken your time to explain about BPH. We do have one question, sir, from the audience side. Shall I repeat it?
Yes, you can.
The one question is there any chances of a diagnosis of BPH in young male whose age is around 25 to 35? So if so, does BPH will affect his fertility?
Yes, nowadays we are coming across younger patients having BPH, though it is very less, but we have come across younger patients having BPH. I have seen a youngest patient of 35-year-old who is having the BPH and who is doing well with the treatment which we have started. 25-year-old, it's unlikely less, but there is a chance that there can be, not that there shouldn't be. So it has to be thoroughly evaluated and seen whether it is BPH or whether there are any other associated symptoms. And it affecting the infertility on the fertility status of the male is unlikely. It's very, we don't see, there is no correlation at all where it does affect the fertility of that person.
I guess the one who answered this one would be getting that answer. And I thank you, sir, for taking your time and for explaining in detail. And I would like to get more and more webinars which will connect. And I would like to close this